Yeah.
Anyway, I'll take over. So welcome everybody. Thursday is time for clinical series with Graeme. So and today is going to be about GI map. So and I will do like last time for those of you who weren't here. And who hasn't met me before. Also, I'm Anne-Catherine, and I'm the co-founder of one of the co-founders of Nordic Labs and DNA Life. And I'll be the moderator. So please ask questions on the side. I'll take them down, and if we have time for Q&A at the end, I'll take some of the questions out. We have quite a few slides to go through. Graeme has informed me, and I have already peeked a little bit on the slides. It looks really good. So it's going to be a busy next hour, but do put the questions down and I'll try and put them together at the end. We are recording, so we will share the recording as soon as we can. Last time, I'm not sure if you noticed, but when we send out after the recording, we send out a handout that you can use. You can share it with your patients, and you can even put it on your website if you want to do that. And we also did that's for that was about the test, so that was about the SIBO test. And then we also did like a handout for you, like a desktop reference in regards to some products and supplements that could be used in order to treat SIBO. And we'll try and do more or less the same this time. And it's really just to help you as much as possible to make it easy to choose supplements if you're new to this, or if you want to get confirmation as what you do already is okay, or just really like, yeah, get inspiration. So, and also you're really welcome to like let us know if there's something, if you have ideas as how we can help you better. One thing is that you learn about the test, of course, and feel comfortable about the test, but also like how you can maybe reach out to your patients easier or something like that. Then we are here to support you, and I already have some ideas up my sleeve that we probably will present in another month's time or something. But yeah, I keep thinking about how I can help you the best, apart from education, of course. So yeah, today is GI map time, and next month on the 25th of March, it's going to be Dutch time. Not in Holland, but the Dutch test. So I will pass on the microphone to Graeme, who is up in Stockholm, and I'm in Copenhagen this time. So yeah, and please write the questions in the end. Remember, we are recording, and yeah, let's hit the road.
Okay, thanks. And Catherine, you can hear me okay? Great. So I'll just share my screen here, and then we can get started with the slides. Okay, so of course today we're talking all things GI map testing related. Really today, well, the goal of the session is of course to just go through some basics. Why is GI map testing helpful, under what circumstances, some basic result interpretation, some treatment strategies, and then to finish with a case study example. Of course, I want to clarify before I start that you know, this is really or this presentation is kind of a basic summary of how I'm looking at the GI map test and how I'm treating certain things and findings on there, as well as the Nordic Clinic team. It doesn't mean that's the only way. There's a lot of different ways to go about treating different things that are found. So just bear that in mind, that like I say, there are different options available. It's not necessarily that the things presented today are the only way. They're just, if you like, a handful of tools that we use at Nordic Clinic to of course help to improve patient outcomes. So when to consider a GI map test? If you're quite new to functional testing and you've not been doing a lot of stool testing before, this is more for you. So of course, functional bowel disorders like IBS, acute bowel issues like food poisoning, any inflammatory diseases locally in the digestive system tract and systemically, like Crohn's, colitis, rheumatoid arthritis, MS, skin conditions, psoriasis, and eczema, neurological diseases, allergies, intolerances, low energy, longevity, weight gain or loss. I mean, the list is really endless because of all this research that we've gathered, certainly over the last 15, maybe even 20 years, and still ongoing, about how the microbiota and how the gastrointestinal tract really influence systemic health. So it's, of course, one of those tests where it's not necessarily ever a bad choice. But of course, hopefully today we're going to cover some things where the GI map test might be a good option. Now, the first thing to say is that the GI map test uses technology called quantitative PCR, and it's going to only look for things that are in the test. So it's not like culturomics, where, you know, if you think like fishing, if you go fishing with a big fishing net, you can catch a lot of different things, whereas GI map is like going fishing for certain fish and only being able to catch that certain fish. So if you're looking for some kind of more unusual fungal infection, then the GI map test might not be the best choice because it only covers Candida yeast and some other ones. So it really depends on what are you looking for. And if you're looking for, you want to look for a specific microbe, then this is a fantastic test to do because it's extremely sensitive. So just bear that in mind when you're picking a stool test. And the benefit of the GI map is it's very sensitive. It can pick up these microbes at very low levels. But if you want to really capture a lot of more unusual things, you want to use culturomics, then the GI map test does not use that technology. So if you're here for the SIBO course last time, very similar diagram. One thing I want to get across is that, you know, GI conditions or issues, that it's rarely just one thing, and there can be a combination of factors that can affect patients or clients over, you know, a slow duration, like sedentary lifestyle, Western diet, PPI, so proton pump inhibitors. Can be things, of course, like alcohol, stress, etc. Or there can be a rapid onset. So if there's antibiotics or nerve damage, food poisoning, autoimmune conditions, or even certain medications, that can lead to, of course, GI symptoms and major problems. Now, on the right here, I've put a list of things in red. So if you're not a medical doctor and a client turns up to your practice, whatever that may be, then if they present with any of these symptoms here on the right in red, I would definitely refer them back to their doctor to at least have some kind of further medical opinion, because, you know, worst case here is that you have a patient with some form of, you know, let's say digestive cancer, and basically you're running a GI map test on that, which takes a few weeks to come back, and you're working on nutrition and all those other factors, but they may need urgent medical management and care. So if they haven't seen a doctor before seeing you, and you're not a medical doctor, and they present with any of these, you know, red symptoms here, often, you know, combination of things, then, you know, for example, if they have rectal bleeding, dark stools and fatigue, then certainly that is, you know, a red flag to refer back to their doctor as well. So, I mean, of course, at Nordic Clinic, we have doctors in the team, so we're able to do that jointly. But when I wasn't working with doctors directly, then I would, any of these red, more serious symptoms here, I would refer to their doctor while also I was doing a GI map test alongside. But anything on the left-hand side here, gas, bloating, constipation, diarrhea, changes in stool consistency, pain, swelling, cramps, burping, nausea, or reflux. These are all legitimate reasons to run a GI map test. So these are the kind of things you should be looking for in your patient history and intake questionnaire to then go into something like a GI map test. First thing we say is you want to try and think big. So the gastrointestinal tract, it obviously has a range of vital organs. So you also have to not just think about the mouth, esophagus, stomach, small and large bowel, rectum and anus, but also consider things like the liver, gallbladder and pancreas. And of course, the GI map, it covers some of these areas in some ways that we'll get into. But then you also have to think about all of the other organs and glands, a very simple one being that, of course, if your patient has an undiagnosed hypothyroidism, then of course that's going to affect the digestive tract most likely. So you could be treating some kind of digestive dysfunction like IBS and constipation that may be driven by a hypothyroid situation. So you need to think about all these other factors as well, get a good intake of what they're doing, how they're feeling, other symptoms, because that may help to point to some other organ or gland dysfunction. And then I think the one thing I've really noticed in clinical practice over the last 15 years is that very rarely do we find one thing on a test that is the cause of all their symptoms. So don't always expect to find the root cause all the time. Very rarely does that happen, in my opinion, on one test. So of course, if there's something like IBS, you might be dealing with dysbiosis, you might be dealing with some kind of pathogenic infection, you might have a hypothyroid situation, poor circadian rhythm, and a sedentary lifestyle in your patient. And you've going to have to look at improving all of those things, or referring to practitioners where you can't help for one various reason or another, to try and obviously solve this in the longer term. So think big, think about the meal preparation like chewing, and think about things like what they are actually eating. Of course, most of us will do that on this call, be looking at the nutrition, and is it more of a Western diet, for example, but really try and get into some detail along the way. Now, basic result interpretation with the GI map, it can be a little bit confusing. Using the example here, some patients will often say, well, 3 is higher than 2. I don't understand, why is this number bigger here? And it's because you need to look at this E5, which tells you how big the number is. So 200E5 is 200,000, and 300E4 is 30,000. So there's a reference table here that you can refer back to. You don't need to understand this at like a huge amount of detail, apart from that this means to the power of, and the bigger the E5 number, or the E number, sorry, on the end of these digits here, means there's more zeros on the end. Now, another thing that sometimes I see is that practitioners, when you're getting into the sections which are not related to pathogens, that they might miss this one. So this means below the detectable limit. So for example, you might find an Akkermansia level that is below the DL, and because it doesn't flag that in the report as being low, sometimes it can get missed. So just be aware of that below DL or below the detectable limit isn't always a great thing for some of these results, but it's not going to be flagged, especially in the beneficial flora section. But the report is usually quite easy to understand, in the sense that anything that's high it's in red and it has high written, like so here, giving one example that C. difficile toxin A is elevated. Obviously, if this patient has diarrhea and major digestive symptoms, then in this case, I would be referring them as quickly as possible to the gastroenterology department for help with that, and then they would take it from there. So the first section is the pathogen section. And again, just, this is an area where you want to be more careful, because you can potentially cause patients more damage in this section if you're not doing your due diligence. So any red flag symptoms that we went through on one of the first slides, with any positive pathogens, then make sure you refer them to a doctor, gastroenterologist, or infection specialist for medical management, because that is very important that they get treated correctly. A number of these bacteria are quite dangerous, and potentially, if not treated quickly enough, could have very serious consequences. So any red flag symptoms with high results here, just refer them immediately back to their doctor if you're not a doctor and can't deal with this. Now, in this section, there's a few of these which we can deal with. So one of them being Campylobacter. So if you are finding Campylobacter, and it doesn't necessarily have to be high. So again, here's a good example here, E. coli 0157, you can see it's 8.60 E0, so it's not above the normal range here. It's considered a normal level that can live in the digestive system without a problem. However, if your patient has things like chronic SIBO issues and IBS, a number of these pathogenic bacteria can sit obviously in that digestive system, causing an immune reaction that's damaging the migrating motor complex. So we want to try and make the environment there more inhospitable to them and try and push them out. So Campylobacter, even if I'm seeing a result that is within the normal range, but you see here in this case, Campylobacter, it's not there at all. So of course, not worried about it. But let's say this E. coli level was in Campylobacter, you could use some oregano oil over perhaps 4 to 8 weeks just to try and remove that Campylobacter away. And then also there are medical alternatives as well if you're a medical doctor. So especially this section, I'm looking for any presence of pathogens. Of course, a lot of my patients are like chronic SIBO, IBS issues, and occasionally, quite regularly, we might find low-level pathogens, and most of the time we're going to use some kind of high-dose probiotics, which I'm going to come to in a minute, to try and push those out. But Campylobacter is treatable with oregano oil. That's shown efficacy against that. And also Campylobacter, it has been linked with anxiety. So if you have a patient with Campylobacter and anxiety, it's definitely worth treating that, and that may take the anxiety away if that's the cause of the anxiety. Now, one question is, of course, how do we treat C. difficile, Clostridium difficile? And there's a number of treatment options. And I think, Petra, thanks for your question. You asked if someone is, so if we have this patient here, that, as I understand, is positive C. difficile, but doesn't have any symptoms, then what would you do? Well, these would be some of the things that I would do. I would be probably using Saccharomyces boulardii, and I might use Probio Defense by Kirkman, and I might use Broccolox because there's some case study evidence of these having effects against C. difficile. But really, I'm using Saccharomyces boulardii mainly as a preventative measure, so prevention of reoccurrence. So I'm going to advise the patient that if for some reason you have to take antibiotics, then you need to advise the doctor that you're seeing at that time that you're carrying C. difficile, and that may determine how you are treated. Now, ironically, for C. difficile, if it is a heavy infection, it's treated with some antibiotics, but of course we also have fecal microbial transplant, which is an option. Again, if there's symptoms occurring and I suspect it's an active infection. But if it's high levels but no significant symptoms, then what I'm going to do is not worry too much about it. I'm going to use Saccharomyces boulardii, some Broccolox, may use high dose probiotics as well. And I'm just generally going to try and improve gastrointestinal health in general to try and hopefully help to gradually push that C. difficile away. Now, in Stockholm, we do, for patients with IBS that haven't responded to other treatments, we can actually refer them for a research project for a transplant. So I know I've seen quite a few Swedes on the call, recognizing your name. So if you do have non-responding IBS patients where you think that an FMT might be applicable, just let me know and I'll give you the gastroenterologist name that you can refer them to. So the other two that can be treated, so we have Vibrio cholerae and Yersinia. So actually consumption of hot spices like red chili works against this bacteria, and then Yersinia. So again, this is an interesting bacteria connected with autoimmune thyroid conditions as well. You've got medical options, or usually you could consider high dose probiotics. So I'm usually talking like 300 billion plus per day. And then you've also got broad spectrum antimicrobial herbs. And my main go-to is usually something like Biocidin here, broad spectrum capsules. There's also medical options there if you're a medical doctor or you work in a team with a doctor that you can use. So for all the other bacteria in that section, you don't want to be messing around trying to treat them with antibiotics or herbal treatments, because it may be contraindicated much more with antibiotics than herbs, but it can initiate quite a nasty kidney condition. So we don't want that to happen. So if there's any other high levels of these bacteria, then use something like 11 strain probiotic powder or Claire Labs complete powder. So they're my, again, standard go-to to try and push those out, to make it hard for those bacteria to thrive and live even at low levels in the GI tract. Now, when we come to parasite pathogens, Cryptosporidium, so you've got a number of different options here: probiotics, supplements, or like herbal treatments, and antibiotics. So basically what I might do is use either a combination of these supplements, might be broad spectrum or single ones of each. My decision really comes from, does the patient have any allergies? How is the patient with potentially taking, multiple supplements at once? Is the patient or client on any other medication? So I'm always checking the supplement medication interactions, because you might find that they're on some other medication that means your broad spectrum formula that they normally use, you can't use it in that case because it's going to affect either absorption or acceleration of the medication. So always check that carefully. So for example, Cryptosporidium, if I've can use it, I'll use a broad spectrum herbal treatment containing a number of these. and then I might use something like Lactobacillus rhamnosus GG alongside it at the same time. Then, of course, at Nordic Clinic, we have doctors. We're able to prescribe antibiotics as well, and some patients, we feel that's the right approach. So we're never closed off to a medical or a pharmaceutical intervention or a supplement intervention if there's efficacy, if it's the right choice for the patient. So we like to keep our options open and use the best tool for the job, and sometimes that is medication. Entamoeba histolytica, there's some evidence that resveratrol helps, but usually I would go straight to the herbal route and use either, again, a number or combination of these herbs here. And then Giardia, especially Giardia, it may cause malnutrition and B12 deficiency. It can cause reactive arthritis. So if you have a patient who comes with these symptoms, definitely look for Giardia. So a GI map is great in that way. Sometimes you might find that if you're using microscopy technique where you have a parasitologist looking down the microscope, then of course, if there's no parasite evidence in that slide, then they'll view it as, of course, negative. But in some cases, due to parasitic life cycles and activity, they can get missed. So again, this is thought to be one benefit to DNA PCR, especially quantitative PCR technology, that it's harder to miss these things. So usually if you see Giardia, then I'm going to use these herbs. These have all shown effectiveness against Giardia. Probably again use a combination, maybe something like GI Synergy. That's one of my favorite products, or Biocidin. And usually for parasites like Giardia, I would be treating for about a 3-month period. If it's a particularly heavy infection with herbs, then I might do 3 months of basically 3 months of normal treatment, and then 2 months of kind of half dose of what I gave in the first 3 months. But usually about 3 months is sufficient in most cases, I would say. Of course, antibiotics here at the bottom. Now, if there's GI viruses, now I've done, I don't know, now maybe a few thousand GI map tests, maybe more. I've certainly looked at thousands of tests from other practitioners. I think it's very, very rare where we see a GI virus, but it does come up occasionally. And again, these are all the antiviral products that we might use. So usually my go-to is Loricidin. That's my most commonly used one, but like I say, it doesn't happen so often. Now, Helicobacter pylori, basically here we have the result in this case, so 2.9E3, which is high, and then we have virulence factors. So basically these virulence factors mean how pathogenic is that Helicobacter pylori and what's that associated with. So, for example, VAC-A is a type of Helicobacter, or it's basically means that Helicobacter infection can damage mitochondria. So again, if I'm seeing something like virulence factor VAC-A, I'm going to treat the Helicobacter first, and then certainly I'm going to consider trying to repair the mitochondria afterwards. And so that could be lipid replacement therapy, for example. Now, if the Helicobacter result is high, I'm going to treat it. That's pretty much as simple as it is. If Helicobacter pylori here is not high, but there's virulence factors, I'm also going to treat it. And if Helicobacter is present but normal and there's no virulence factors, Then I'm going to look at the client or the patient symptoms, and I'm going to make a clinical decision about whether do we need to treat that Helicobacter. I'm going to look at other patterns in the report, and I'm going to see, is it possibly the most important thing to do first? Like, for example, if they have a protozoan infection, like a heavy Entamoeba fragilis infection, and Helicobacter is present but normal, then I'm probably more likely to treat the Entamoeba fragilis ahead of the Helicobacter. So it's always tough. I don't have a perfect algorithm to give you to say when or when not to treat it. Those are my basics. But if especially there's any like GERD, reflux, if there's something like SIBO, I mean, if there's any, of course, you're most likely doing a GI map test because there are symptoms. So usually if we find Helicobacter pylori at a normal level, no virulence factors, I think you have to make a call on whether to treat that or not. And if you're using some of the supplement treatments, then they're probably not going to do the person any harm. But of course, some of these are quite expensive. So you need to weigh that up against all of the other results and decide what's priority here. Now, usually my most favored Helicobacter treatment is Maturity. And then often I'll combine Maturity with Helico-X or GI Pro HP, especially if they're quite, so again, you want to look at the number, see how high it is above the normal limit, and then decide how heavy you're going to go in with your treatment or your intervention. So certainly once we start getting, if we see anything above like E3, so once we see E4 or higher, then I might use multiple products. But this case, like 2.9 E3, I probably would be using 1 month of Maturity, and I would probably combine it with this L-Reuteri DSM formula, also known as Pylopass. And I would do that probably at the same time for 1 month, and I would extend the L-Reuteri most likely for a second month. If they've got if they've had this like chronically for a long time, then I'd be looking to more go in for Maturity, Helico-X, GI Pro, and L-Reuteri. So often I use those in combination, but it's pretty much the most expensive protocol that can come out of a GI map report. But it's very effective. I've used the Maturity for years, and I've never had a bad result from it, although I have had colleagues who've used it and had some patients that don't respond. But I would say the response rate to Maturity and Helicobacter it's very, very good. And of course, that saves the patient often or client having to have triple therapy, with proton pump inhibitor and obviously 2 heavy antibiotics. So I think the main thing with the GI map is to try and look and recognize patterns. So you want to view the whole report and you want to look for, is there pathogenic infection? Is there infection, but it's not pathogenic? So, like I talked about, you might have low-level infections that are just, or low-level amounts of pathogenic bacteria. It's not considered an infection, but it's there. Yeast, Candida, Protozoa, are there absorption, immune, or inflammation issues? I'm looking at the overall low in beneficial bacteria or their phyla. Are there high levels of opportunistic bacteria? And is there a high or a presence of autoimmune triggering bacteria? So I don't get too bogged down if there's one that's a bit low, there's one that's a bit high in normal bacterial flora. I'm not going to worry about it, because all the microbiome is very different from person to person. It can depend on stress, eating patterns the day before the test, things like that. So generally, the worst thing you're going to see is when a couple of things are low, a couple of things are high, but overall, I'm looking for major patterns from this test. That's what I want to see to do a good intervention. So if you get the report back, and if we have something like this here, I'm going to treat the Helicobacter pylori first, and then I'm going to go on to treating the low beneficial bacteria. Of course, from a supplement perspective, we have things like Biotigen and inulin. So it might be so this one on the right-hand side here, it might be that the whole report is quite good, but then you look at the beneficial bacterial section. This is an older test result. You see it doesn't have Akkermansia and Faecalibacterium and Protozoa. Then it might be a simple case of you need to boost their beneficial bacteria, and you can use supplements. Of course, you can use dietary intervention with prebiotics. They might need stress management because, of course, high stress is a very easy way to ruin the microbiome. So if that's the case, then my usual go-to, I like Biotigen. It's a different combination of prebiotics, but really I'm going to work mainly with food and diet. So, trying to get them away from a Western diet, if that's the case. And then also be aware that if they have things like diarrhea, then they may just have low levels because of the diarrhea. So it's a tough chicken or egg type question. Did the low beneficial bacteria cause the diarrhea, or is the diarrhea that they're having, of course, they're ejecting a lot of bacteria. Is that why you're seeing this? So you need to bear that in mind. Now, if there's high opportunistic bacteria, then classically I'm going to use broad spectrum formulas. Depends how much and how far these are past the ranges. When I'm looking here, so again, methanobacteria, say anything around E7, I'm starting to also suspect SIBO just from my clinical experience. So 5.38 E7. Certainly, I would consider that methane SIBO is a possibility. So you're looking for, especially, do they have constipation? Are there signs of postprandial bloating? So that can be an indication to go in and maybe also perform a SIBO test. Things like this. So E3, E4, E4. Okay, E7's a bit more significant. But if this was the worst thing on the report, I wouldn't be too worried. I actually wouldn't be, probably, if everything else was good and this is all we found, I probably wouldn't even be doing anything with that. I'd be just generally improving the health of the patient and obviously working on everything that affects the GI tract. But if they have significant symptoms, certainly would consider SIBO here. So of course, some of this is, the test is just providing you with information to help you make a better decision about what to do. Now, with potential autoimmune triggering bacteria, you also want to look at the patient's symptoms. So if the patient has rheumatoid arthritis and they've got Prevotella living in the digestive system, we know that this can exert molecular mimicry that can trigger that condition. So even though it's there at normal levels, I'm gonna do my best. Can we try and get rid of that? I'm certainly going to be trying making sure that the patient doesn't have increased intestinal permeability. Now, if you're seeing multiple things, high levels here, if you're seeing a number of high levels or things here, then my general approach is usually to use broad spectrum formulas, but especially Klebsiella, which is well known to produce biofilm. I use something like Biofilm Defense by Kirkman alongside herbal treatment. Now, if your patient has no history of autoimmune disease, and you find things like this, again, I'm not gonna worry about it. But if they have even things like this, if there's a family history of rheumatoid arthritis, in this case, we're finding this here, I'm going to want to improve their digestive function as much as I can. I'm not necessarily going to be able to totally get rid of this Prevotella, but if we can stop excessive intestinal permeability, if we can make sure the beneficial flora is good, the function is good, there's no inflammation, digestion's working well, there's much less risk of this Prevotella going on to cause an autoimmune trigger. Candida, so my general opinion is if Candida is growing in the digestive system at levels like this, I mean, it's opportunistic. You need to build the resilience of your client. There's not enough resilience there in the digestive system to keep it under control. These are some of the treatments that are used, definitely something like Saccharomyces boulardii. You can go for any number of these different treatments available. So one downside of using the GI map test is we don't get a susceptibility report. It's not like where there's culturomics is used and you can see what it's susceptible to. So you have to go with one of these options, and then you need to be prepared to change if it's not working. And something we use a lot of at the clinic is nystatin, which is, of course, the medical option drink that stays in the digestive system. And that's been very, very effective at clearing things like yeast and Candida. So for me, generally, Candida, things like this, I might do some treatment. I'm not going to have them on extended, long treatment for Candida. I'm going to try and build resilience, because generally, if you build more resilience in your client, what we see is that these Candida infections will resolve and stay away a lot easier. Now, protozoa and worms. So usually worms, if there's anything detected, again, it's very rare. I've probably had, on one hand over the last, 5 years or so where I've got positive results here. Again, usually it's a very simple medical intervention. It's one pill and it gets rid of those. So normally if you find anything there, just refer them to the doctor to get that prescribed. But yeah, so that's the best option in this section. Protozoa is always difficult. Now, there's a lot of controversy around Blastocystis hominis. We've got the different types, which we now are able to start measuring in some stool analysis tests. And of course, there's an ongoing debate about, is it a problem or not? Now, things like this here, these two, if we take in account for the results that we've already looked at, like the low bacterial flora, the Helicobacter pylori, maybe high opportunistic bacteria, this becomes less interesting to me. So if there's more important things in the report, I'm going to focus on Helicobacter or very low levels of beneficial flora before I start going in and consider trying to treat Blastocystis hominis. It's not always easy to treat. It can be very difficult. It's certainly difficult to get rid of. Again, my focus more and more is moving away from treating these protozoa directly, because there's some research saying that certainly with certain subtypes that Blastocystis is very helpful, actually. I just see it's quite hard clinically to clear it. So it's more about creating a GI environment that doesn't allow the Blastocystis to really take excessive control. Entamoeba fragilis is definitely one of these here that if it's borderline high or high and the patient has IBS, then yeah, absolutely, I'm going to be much harder on that than I necessarily would with Blastocystis. Now, if I've worked on multiple things with this client, and basically there's been a lot of improvement, but there's still some things remaining, I may try and actually treat these protozoa and see if it helps. But in my experience, it might not do. When we're doing repeat testing, different protozoa can come up. So I'm coming more to the conclusion, as in the research, that these protozoa do come and go. Some of them may actually be beneficial, and a lot of the time, I think they may get over-treated, where it's more about developing resilience in the GI tract. So just bear that in mind. Now, intestinal health, this is a really important section. Of course, if calprotectin's high, it's a red flag. If occult blood is high, it's a red flag. If elastase is very low, below 200, it's a red flag. I mean, again, you need to look at symptoms. If steatocrit is very high and there's pain present, there may be, it could be some kind of liver or gallbladder issue. Again, it's a red flag. So you always need to look at the symptoms of your patient and basically, or client, whatever you call them, and then obviously refer them out. Just to, if you're not a medical doctor, it's better to be safe than sorry, and refer them away for help or an opinion. Now, if the steatocrit is high like this, I'm going to use classically lipo-gold. If elastase is also getting towards 200 like this, 238, then I might just use a broad spectrum digestive enzyme that includes both lipase and, of course, a whole bunch of different enzymes to help support the pancreas. If elastase is 300 plus and steatocrit is high by itself, I'm probably only going to use lipo-gold in that case. Then you need to, of course, understand, why is there a problem breaking down fats? Because that's what this is telling you. So is it because of a Helicobacter infection that's then influencing the communication and the release of bile from the liver? Is there something else going on? Is the patient highly stressed? Are they on a very high fat percent ketogenic diet and they're not tolerating that very well? But you don't want large amounts of fat really going into the large intestine. That's a bit of a lipopolysaccharide nightmare. And we know that especially saturated fats does increase leaky gut, as we call it, or hyperpermeability. Beta-glucuronidase, if that's high, I'm usually going to use something like calcium D-glucarate or milk thistle to help get that down. But that's just telling you there's a dysbiosis, a type of dysbiosis going on. It can also affect estrogen reabsorption. So especially if you have women with hormonal symptoms and they have high beta-glucuronidase, then it's probably telling you that estrogen's being reabsorbed back systemically. It may be, so I've had cases where the women have been very low in estrogen, and one theory could be this is an adaptation to actually help their estrogen levels. But I've also had estrogen dominant, as we call them, women, so high estrogen levels as per testing, and then high beta-glucuronidase. So I'm going to get in one of these two supplements to help, and then I'm going to start to look at their diets in particular to help to change that. Occult blood, as I said, if that's high, it's a red flag. Refer out to the doctor or gastroenterologist for further investigation. So it's always good to ask your client or patient, have they had a colonoscopy, endoscopy, or any other kind of invasive observation or investigation? Because you can always say in your clinical notes that patient has IBS, but no endoscopy or colonoscopy has been done, and would suggest next time speaking to their doctor to bring that up and have that conversation. Because then if the doctor says, no, we're not going to do that, that's fine, you've covered your back. But that's something that I encourage my team to do if it's not a doctor supervised meeting, because it just covers their back. They've let the client know what to ask for, and then it's their doctor's choice. So in regards to immune response, secretory IgA, I using that more as a marker. So what's going on with the immune response? Is it generally low or high? And then, of course, based on my intervention, how is that marker changing? So you could use things like, you could use Mega IgG 2000 from microbiome labs. You could use ImmunoGG. You could use, Saccharomyces boulardii. You could use things like zinc, and there's other fatty acids as well. So sometimes I may do that if secretory IgA is especially low. So below 200. If they're really prone to digestive infection, if they usually have SIBO, of course, low SIG-A is a risk factor for SIBO, then I may use one of these. Otherwise, I'm using that as a marker to say, is my intervention, is it helping? Is the secretory IgA increasing if it's low, or is it decreasing if it's high? And of course, if it's high, I'm looking for also things like food antigens. So is the reason this high because of infection or imbalance, or is it something from the environment like food? And then anti-gliadin IgA probably speaks for itself. If it's elevated, then usually we're going to get them on a gluten-free diet. If it's elevated and they're on a gluten-free diet, then one thing we may consider is a gluten cross-reactivity free diet, and see if that helps, of course, coming from a molecular mimicry perspective. And then we also have calprotectin here. So if calprotectin is elevated, the patient is aware of that, they're under some care from their doctor or gastroenterologist, and I'm trying to help lower that, then I'm going to use things like GI Revive or Brocolox. So Brocolox, sulforaphane is a great NRF2 stimulator, so it really gets the antioxidant defense system working in the gut. Same for celery juice. So again, some patients with high calprotectin, I'll use celery juice. I'm not going to use celery juice on every client that we see. I'm going to pick the ones, especially with borderline high or high calprotectin. But again, this is, major red flag. So they need a referral to their doctor if they're not under supervision or they didn't realize they had high calprotectin. Okay, zonulin, so it's an add-on marker. It's one marker of intestinal permeability. Just because they have normal zonulin does not mean that they have great digestive function and no excessive or hyperpermeability going on. I generally think that zonulin is more, it's more elevated through potentially gluten consumption, but of course, vitamin D can help with this situation, as well as total removal of gluten or grains. But then you can also use things like deglycerized licorice, you can use butyric acid, you've got glutamine and GI Revive. Normally, I'm going to use something like GI Revive with butyric acid, but the only problem is that things like GI Revive with a lot of ingredients, for some patients that are sensitive to a whole variety of factors, they may not tolerate it. So you might need to start with something very, very simple, like just DGL or butyric acid, work on their digestive system overall, and then, of course, go from there. I just wanted to go through a quick case study because we're about to run out of time. But this was, 40-year-old male entrepreneur, ulcerative colitis diagnosis, blood and mucus in stool every day, and can have up to 12 toilet visits per day. Has osteopenia, under care for that, low testosterone and anxiety. Wants to return to a normal life, wants to improve sleep, having a problem with sleep, increase energy, reduce fatigue, doesn't want to be on medication, and was a vegan. So I've included some studies here because UC is well known at causing osteopenia, and ulcerative colitis can also cause low testosterone. We're looking at anxiety, was that the trigger for IBD? But certainly we know anxiety can cause IBD flares. Our goal was to try and put the UC into remission and obviously help with fatigue and energy. He had been using cortisone some years ago. He was on testosterone replacement therapy, using some melatonin and benzodiazepine occasionally when needed. So this was the first test. You can see, so no pathogens going on here, all below the detectable limit. Found Helicobacter pylori, some high Clostridia, not too worried about that. But this is where some people get caught out. So Akkermansia was below the detectable limit. And then we've got low bacteroidetes going on. Just a couple of opportunistic bacteria. We've got a number of potential autoimmune triggering bacteria here as well. No fungi, yeast, no viruses, no protozoa, no worms. Stetacrit below the detectable limit, great. Elastase looks okay. I mean, could be better, but I'm happy with that. Then we can see beta-glucuronidase just above normal limits. Blood very high, 102. And then we have secretory IgA and antigliadin. So secretory IgA normal, antigliadin raised, and then of course we've got calprotectin, which I can't see because something with Zoom is blocking it, but I know it's quite elevated from this test. Let's see if I can move this. Yeah, 6,449. So very high calprotectin score. So what I did with this patient was I gave Matulity. I wanted to work with the Helicobacter pylori first. So I gave Matulity, Helico-X, GI Pro HP, and L-Reuteri. So these I just did for 1 month, but I carried on the L-Reuteri for a second month. Did an AIP plus gluten cross-reaction diet. So it was quite a heavy intervention. And this was administered by Christina, who's one of my colleagues here, nutritional therapist at the clinic. And basically, because we were eliminating a lot of things, we got this client, this patient, starting to eat meat again, and he was open for that. He was been doing vegan because he thought it was a healthier option. Worked on the routines. The main thing I did really was time restricted feeding. So I got him into a 10-hour window to start with eating rather than 12 to 14 hours. So you can see here, so we've got the old result on the left and the new result on the right. So no difference 3 months later. But then we see we've taken Helicobacter from high level to more normal. It's not totally gone, but it's a lot better. And we did go quite hard in with that treatment. So we've got some minor change. You see there's no change with the Akkermansia here, but this time Escherichia is a bit high. We've got bacteroidetes to normal, but Firmicutes has increased. We've got a bit more opportunistic bacteria this time. But again, nothing that I'm too worried about. Apart, I mean, this Morganella is much more increased, E8, and the Methanobacteria E9 from E7. And he's still complaining a bit of gas type symptoms. So I really suspect he's got methane dominant SIBO. Then we can see there is some Entamoeba fragilis now, but no worms. However, the key section and results are below here. So we can see that beta-glucuronidase is totally normalized. Occult blood has gone down to 2 from 102. Secretory IgA is a little bit lower, but similar. Not too worried about that with him at that stage. And we can see his antigliadin is totally normal, and we've got his calprotectin down from over 6,000 to totally normal level 80. So basically, just with those changes, he's gone from was having blood in his stool every day and mucus. And he, at the 3-month point, he'd now been blood free for 2 weeks, and also the mucus in the stool had stopped. He went to the bathroom only 1 time. So for the last 10 years or so, he'd been going 10, 12 times a day. His sleep has improved, but it was not perfect. And his energy is now much higher and less fatigue. So it was a very, very good result from 3-month intervention, mainly of Helicobacter treatment primarily, and of course some particular diet interventions and time-restricted feeding. So really, really fantastic. So there we go. That's the whirlwind over.
Excellent. Sorry, I couldn't find my unmute button. Well done, Graeme. You must be a little bit stressed now, but it's over nearly.
It's just a few minutes over.
Well done. So many questions have come up on the side. Many has been very, very specific, like into one parasite or one bacteria and so on. So I've kind of kept that a little bit on the side because many questions came up. I just want to announce, just in the middle of writing down on the side here, because like today, of course, the topic is GI map, and last time it was SIBO, but I just want to pay your attention to the fact that both Graeme and myself and our practitioners would very often run both a SIBO and a GI map in combination in order to know more. And in Nordic, in the VMS system, when you're in there and look for tests, you can see bundle packs. So sometimes you can find like let's say a stool test with a SIBO and an organics, and then the patient will get some discount if you order more in one go. So that's just really nice to know, because it means that you can get more information and save some euros or whatever the patient is paying in that case. So just pay attention to that, and please just reach out to us if you have questions, or if you can't find it, or it's not everything that we create bundle packs on, but some are there for sure. So one question came up that I thought was very important in regards to low elastase. And so I, for sure, if I have a low elastase, let's say 20 or something like that, or a little bit higher, but low in general, and then I would always refer back to a doctor and have it checked. And I've done that a couple of times, and in Denmark, for sure, they take it quite serious. But we also have just had a case where it's low with us and it's normal with the doctor. And now I didn't write down the name, but there was one who wrote in the comments that he or she had experience with parasites making the elastase plummet down. But Graeme, you would refer as well if it's that low on elastase?
Yeah, I mean, if it's that low, I mean, usually if it's once you get significantly below 200, then we're going to refer for sure. I mean, so yeah, I think it's really important that, especially if there's pain, or there's some kind of or there's more like yellow stool, things like that, then you should definitely refer out. If it's 200, you're kind of on that borderline, and if you're not comfortable, I would certainly, you're always going to be safer by referring. Just get the patient to, if you're not a doctor, you're always going to cover your back by referring that out and just checking, is the elastase okay, is there some deeper issue going on? So that would always be, if you're unsure, if there's significant symptomology with a borderline low or a low elastase, then definitely refer out. It doesn't, you can still work with them, you can still work on your things and do what you're doing. It doesn't mean that you stop, but you're just waiting for them to have maybe more investigation if it's warranted.
Super. So another question came up, and I think that's it's of course relevant just really to bring it up and talk about it in general. Now, this was more specific in regards to some of the antimicrobial supplements and the use of tamoxifen, but I'm gonna change the question a little bit and just pay attention to that some of these supplements can impact some of the cytochrome P450 enzymes. So you may, and some may not, but you may want to like choose something safe if people are on medications as well. Do you have any comments?
I use the Natural Medicines database. It's kept by a group of pharmacists that are regularly looking at the research and interactions between drugs and supplements and different conditions. If you're a member of IFM, I believe that's free as part of your package. It's not so expensive, and I use this guide a lot. A to Z guide, drug, herb, vitamin interactions, to always check contraindications for medication and supplements.
And what else came up? Yeah, so a few questions came up to like when to use what tests and so on. And we do offer several or different types of stool tests from different laboratories. And today is just the focus of GI map, and not next time because that's Dutch, and then I think it's organics, but then CSAP times 2 or GI 360 is going to come up, and GI fix. So just want to say that there is not a stool test that is a perfect stool test. That is the stool test you have to use for all your patients, because that's the stool test. Because like this test we've been going through today does not have the smart new fancy word for short chain fatty acids, postbiotics, in it. But other tests do, so like CSAP times 2 does have the short chain fatty acids in it. So it depends a little bit what you want to know. You may also want to choose GI map because it's only a 1-day collection as opposed to some of the other tests. Where if it's a child, it's easier with just a 1-day collection compared to several days collection. So there's things like that. But we will send out a comparison chart for you so that you can compare what the different stool tests have in them. So that's perhaps easier for you to choose. We always have our, I guess, a little bit favorite test. And I know GI map is Graeme's favorite test.
Well, it's not my necessarily the favorite, but it's I think a lot of my, I guess quite a lot of my clinical work is chronic IBS, like SIBO cases. So I really like the GI map because it measures the pathogenic bacteria which affect the MMC to that quantitative PCR level. So that's the one I probably use most regularly in clinical practice, but we are using other tests like CSAP, GI 360. I mean, I think you made a good point. It's, well, what are you looking for? I mean, there's no point using the GI map if you're looking for short chain, or you want short chain fatty acids. And that may be more beneficial, for example, if you're really focusing on mitochondrial health, to have short chain fatty acids, because how they communicate with the mitochondria. So I think that you made a great point there, and Catherine, that it really depends on what you want to know as to what test you pick, and really that's what I'm trying to teach all the team here in Stockholm is to pick the right test for the right patient, based on their symptoms and what you want to find out.
And of course, sometimes it's also a question of costs. I mean, we can refer to a test that's expensive, but if it's a student or someone who's unemployed, or then we of course may have to compromise and say, well, we're only going to look for dysbiotic or just bacteria, or just to choose a smaller test in order to save some money. That goes with food intolerance tests. I never really mention the small test that only has 96 foods, I always really just mention the 184 foods, because if you do the small one, then you have questions that you could have answered if you did the bigger test. But sometimes we have to look at finances as well for the patient. But it's also our job to advise our patients as what is the best test for you in this case, and not focusing so much on the expense of the test, because the patient has come to us to get optimal health support.
Yeah, I mean, there's pros and cons to each of the different tests, and it really, I mean, that's possibly another lecture on the pros and cons of each different test, and maybe where if you're a beginner or you're used to seeing a lot of stool testing, might also decide what you do, because different tests have different commentary. If you're using like culturomics, then you get your intervention at the end of the report, whereas obviously if you're using something like GI map, you don't have that given to you at the end, because obviously that doesn't work that way with DNA. They can use antibiotic resistance, but of course that's only applicable for doctors prescribing antibiotics based on the report.
So some question came up in regards to more specific questions, and reach out to your practitioner support, or reach out to us if you're sitting with a result and you're thinking, my goodness me, what should I do here? Then of course we are happy to help in the extent that we can. What you sit with might be new to us, so then it's not, there's some parasites that not come up very often, and so it's not that we have a lot of experience with these, but then there's some where we have a lot of experience. So then, but we can go back to the lab and we can discuss it with others and so on. So use us as a resource if you're sitting in a pickle, or if you need to discuss something with us. Then we might have some clinical pearls to throw around with us or around us. So I think that's it for today. So no, we have not sent invites out for the Dutch yet. That will come. It will come with a recording and the slides from today and whatever material that we think will be relevant for you. So look out for the invite, and hopefully see you in about 1 month's time. And Graeme, as usual, sterling, excellent presentation. We love you.
Thanks. You have to say that.
Of course I do.
You're stuck with me.
Yeah. Well, I wouldn't invite you for this job if you weren't good at it. So
thanks. Yeah.
Take care. Bye everyone around the globe. Take care.